Welcome to the Rad-On Smart Review Head and Neck Cancer series.
We're really excited to get into this one.
Yeah, today we're embarking on a comprehensive high-yield tutoring session. We're going to be targeting the essential framework that dictates how we manage head and neck cases, both in the clinic and, for the boards.
And we're going to focus on the AJCC Eighth Edition staging system. But, and this is the important part, we are only focusing on the staging decisions that actually force a change in your management plan.
Exactly. Because, the initial approach for a lot of trainees is to see staging as, well, just administrative. It's paperwork you do after the fact.
Right. Checking boxes.
But in the 8th edition, especially for head and neck, staging is really this sophisticated decoder ring.
I like that analogy, a decoder ring.
It really is. It immediately reveals the underlying biological driver of the disease, what you expect in terms of failure patterns, and, most critically, those few high-risk variables that force you to dramatically intensify treatment.
So we're not aiming to memorize every single entry in every chart.
No. Not at all. We're here to master the handful of concepts that really flip the switch on your treatment algorithm.
Okay, so let's anchor this. How are we going to start?
Let's anchor this whole discussion with a puzzle, a challenging one. Imagine you have two patients presenting back-to-back in your clinic, and on the surface, they look almost identical.
Okay.
They both have a primary tumor measuring 2 centimeters and a single 3-centimeter non-fixed ipsilateral lymph node. So, based purely on that, they both look like a clinical T2N1.
Seems straightforward so far.
Right. Now, for patient A, this is a 50-year-old non-smoker. He's presenting with a 2-centimeter tonsil mass. Biopsy comes back, squamous cell carcinoma, and it tests positive for P16.
Okay, P16 positive tonsil. Got it.
And then there's patient B, 60-year-old heavy smoker. He's got a 2-centimeter lateral oral tongue mass. Biopsy is also squamous cell, but it's P16 negative.
Ah, okay. The plot thickens.
So the crucial question we have to answer for you, the resident listening, is, are they the same stage? And do they get the same treatment pathway?
The historical sort of knee-jerk impulse is often to just say T2N1 stage 3 for both. But that's not just inaccurate in the 8th edition.
It's potentially unsafe practice.
It's absolutely unsafe. Which brings us to the first immediate pre-staging question you have to internalize. Before you do anything else, you have to ask, what staging book am I reading from?
That's the core framework.
It is. Head and neck cancer is not one disease. It's a collection of distinct malignancies, and the AJCC recognizes this. It essentially divides the field into 3 distinct staging systems.
And if you mix them up?
If you accidentally mix the logic between these systems, you risk dramatically overtreating. Or, much worse, dangerously undertreating. And that leads to major local regional management failure.
Okay, so let's unpack this. This split, it's geographical, it's epidemiological. The staging logic is completely driven by the site and the risk factor, which, defines the biology.
Absolutely. So while the AJCC covers everything, oral cavity, oropharynx, nasopharynx, hypopharynx, larynx, we're really focusing on the 3 systems that have these fundamentally unique frameworks. And it's all because of their biology.
Right. That's the key to risk stratification.
System 1 is defined by and really dominated by HPV-mediated disease. This is your P16 positive oropharyngeal cancer.
So we're talking tonsil, base of tongue, soft palate, the oropharyngeal walls.
Exactly. That system is driven entirely by this highly favorable viral biology.
Then you have System 2.
System 2 covers let's call them the older, more aggressive P16 negative cancers. These are driven by carcinogens, tobacco and alcohol.
So that's most of the other mucosal sites. Oral cavity, floor of mouth, lateral tongue larynx, hypopharynx.
That's the one. Defined by traditional risk factors and tumor behavior. It's a different beast entirely.
And finally, System 3.
System 3 is the nasopharynx. The pathology there is unique. It's highly endemic in certain regions, and it has this strong link to EBV. So this system basically ignores size in centimeters almost entirely.
Right. It's all about local geography and deep infiltration.
It is. So those 3 drivers, HPV, tobacco, alcohol, and EBV, are the anchors for the 3 separate staging systems you absolutely must master to treat these patients safely.
Exactly. So let's start right where patient A falls. System 1, the HPV-mediated P16 positive oropharynx.
Okay. The core principle here is really intuitive, but it is critically important. This system intentionally and dramatically downstages the disease.
Compared to older editions or other sites?
Right. And that's because the prognosis for HPV-positive disease is just inherently so much better. I mean, we are talking about 5-year overall survival rates that can approach or even go over 90%.
Even for tumors that look pretty advanced locally?
Even then. Now, the T category is size-based, but it has a few crucial nuances that residents often miss under pressure. T1 is a tumor that's exactly 2 centimeters or less.
So our patient A, with his 2-centimeter tonsil mass, is a T1.
Assuming all other criteria are met, yes. He's a T1. T2 is anything greater than 2 centimeters and up to 4 centimeters.
Here's where it gets interesting, though. T3. This is a classic area of confusion.
It really is. T3 is a primary tumor greater than 4 centimeters, or R extension to the lingual surface of the epiglottis.
And that T3 definition, the part about the epiglottis, it really seems designed to be a board trap. I often see trainees misinterpret that as automatic T4 disease because historically, any laryngeal involvement was a huge red flag.
It was.
So there's fundamental difference. How should we visualize this T3 extension versus a true T4?
That's a great question, and it really gets to the importance of anatomical precision. The expert insight you need is this. Do not automatically overcall T4 just because the epiglottis is mentioned.
Okay.
If the tumor extension is only to the lingual surface, that's the side facing the base of the tongue from a primary in the base of tongue or vallecula, that's T3.
So what defines a true T4 invasion then?
True T4 is invasion into adjacent, functionally critical structures and deep spaces. We're talking about invasion of the larynx itself, bone invasion like the mandible or pterygoid plates, deep extrinsic muscle invasion, or true encasement of the carotid artery.
So that lingual surface extension, it's a regional advancement, but it doesn't carry that same catastrophic weight.
Exactly. It's not the same as those deep structural invasions, which is why it's kept at T3.
Okay, that makes sense. Now let's shift to the clinical N category in this P16 positive system. The AJCC simplified it dramatically.
They really did, and it reflects the better nodal biology of HPV disease. Laterality and a single 6-centimeter cutoff are the absolute key drivers for clinical staging. It's that simple.
So let's define those 3 simple N categories.
Okay, N1 is 1 or more ipsilateral nodes, as long as none of them are larger than 6 centimeters.
Ipsilateral under 6 centimeters. Got it.
N2 is defined by contralateral or bilateral nodes, but again, none of them can be larger than 6 centimeters.
Okay, so the key there is crossing the midline.
It is. And N3 is just simple. It's any node, doesn't matter where, that measures larger than 6 centimeters. That's your cutoff.
The key takeaway here, and this is a massive distinction from the P16 negative system, is that there is no N2A, N2B, or N2C subdivision in the HPV positive clinical staging.
None. That simplification is completely intentional. It recognizes that for prognosis, the exact number and location of nodes are less critical than just the sheer volume. Is it bigger than 6 centimeters and the presence of bilateral disease?
And here is the second, and maybe even more critical, board trap, extranodal extension, or ENE.
Ah, yes, ENE.
Whether you suspect it clinically or it looks convincing on a scan, ENE does not change the clinical N category in this P16 positive system.
This is a huge point. You might see radiographic signs of ENE on the CT or the PET scan, and that's certainly important for prognosis, but under the 8th edition, it does not upstage that node. It doesn't go from an N1 to an N3B like it would in the other system.
Let's bring this back to patient A. We have a 2-centimeter tonsil mass, so T1, and a 3-centimeter ipsilateral node, so N1. That makes him stage 1. Period.
Correct. Stage 1. Regardless of any imaging suggestion of ENE.
Now that's all for clinical staging. What if patient A went to surgery first? The pathologic N category is a bit different, right?
It is. It reverts slightly to a more nuanced view. The pathologic N category is driven by the number of involved nodes, not so much the laterality.
So what are the cutoffs?
Specifically, if you find 1 to 4 involved nodes after the dissection, that's classified as PN1. If you find 5 or more nodes, that's PN2.
Which confirms the clinical staging system is really designed to capture that excellent prognosis of HPV biology and to guide our definitive non-surgical treatment volumes.
Precisely.
Yeah.
And that brings us to the stage grouping. Because the TNN categories are compressed and simplified, many patients who were historically, saddled with a grim stage 4 label are now comfortably stage 1 or stage 2 in this system.
And that's the whole point of System 1. The stage is now highly prognostic.
It is, but, and this is the clinical pearl you must always be ready to articulate on your boards, this new favorable stage is prognostic, but it is not automatically prescriptive for de-escalation.
What do you mean by that?
I mean, you can't just lower the dose or shrink the treatment volume just because they are stage 1 unless you are on an explicit, proven clinical trial or protocol.
That is such a critical nuance. So the stage 1 or stage 2 label, it gives you enormous confidence in the long-term prognosis, and that's great for counseling patients.
It's wonderful for that. But you still have to treat the disease burden in front of you. That means definitive full-dose radiation, typically 66 to 70 gray, targeting all the required primary and nodal fields.
Unless you're following a specific protocol.
Right, like some of the NRG or ECOG studies that have been designed and proven to safely reduce intensity. At the end of the day, you're managing the biological risk, which is low, but you're not just treating a low stage number.
Okay, now we have to pivot hard. Let's go to System 2.P16 negative and other mucosal sites. This is the oral cavity, larynx, hypopharynx. And here, every single rule we just talked about is immediately broken.
Absolutely. We call this the ENE system because extranodal extension is the single killer variable that changes the entire staging and management landscape.
What's fascinating here is that we have to speak two very different specific languages when we talk about ENE. You have clinical ENE,
which drives up staging,
and you have pathologic ENE,
which drives treatment intensification. Two different concepts.
So clinical ENE, that's your suspicion, right? Based on exam and imaging.
Yeah.
How do we define that suspicion in clinic?
You'd be concerned for clinical ENE if the node is, rock hard and fixed to the underlying structures, or if there's skin involvement over it.
What about other signs?
If the patient presents with a new, unexplained cranial nerve dysfunction, that's a big one. Or if the CT or MRI shows really convincing features, like a loss of the smooth nodal margins, infiltration into the muscle or fat next to it, or just an irregular shape.
And this suspicion of clinical ENE automatically upstages the clinical N category significantly.
Hugely. It can jump from an N1 to an N3B. That's a massive contrast to the HPV system we just talked about. And this clinical upstaging, it helps drive aggressive upfront management decisions. You're often thinking about chemoradiation or, if it's operable, a very wide neck dissection.
Okay, so that's clinical ENE, then there's pathologic ENE.
Right, and that's the gold standard. It's confirmed by the pathologist after a neck dissection. They'll describe it as tumor cells extending through the capsule and into the soft tissue around the node.
And this distinction is critical because pathologic ENE is one of the strongest management drivers in all of head and neck cancer.
It is. It's the key indication, and this is based on 2 landmark trials, to add concurrent systemic therapy, usually cisplatin, to postoperative radiation. This is a non-negotiable, must-know fact for your boards and for safe practice.
So let's take an example. You have a patient with a P16 negative cancer of the larynx. They have surgery, and the pathology report shows high-risk features, specifically pathologic ENE.
Or positive margins or multiple involved nodes, but ENE is a big one.
You've crossed a critical management threshold there.
You have. The risk of recurrence is so high that combination treatment is required.
Yeah.
And pathologic ENE often provides the single largest benefit from adding that concurrent chemo. That's what RTOG 9501 and EORTC 22931 showed us.
Could you delve into that a bit? Why do those trials make pathologic ENE such a powerful factor? It can't just be the presence of cells outside the node. It must reflect something more aggressive about the biology.
Absolutely. What's fascinating is the quantitative difference ENE makes. The EORTC trial, for instance, showed that for patients with positive margins, or ENE, adding chemotherapy improved the 4-year overall survival from 37% all the way to 53%.
That's an enormous benefit.
It's huge. And ENE was a consistent predictor of failure in the arm that only got radiation. The simple presence of ENE confirms the tumor has already escaped the lymphatic capsule. It's invasive, it's aggressive, and it has a high probability of microscopic spillage or satellite lesions that radiation alone just has a hard time controlling.
So it's a tumor that's basically screaming for systemic help.
It is. It's screaming that it needs systemic help to clear out those occult foci. It makes the chemoradiation combination a necessity, not an option, unless there's a contraindication.
Okay, let's connect this back to patient B, the 60-year-old heavy smoker with a 2-centimeter lateral oral tongue mass. The oral cavity, which is part of System 2, has a very special gotcha. that completely overrides the surface size.
And that is the depth of invasion, or DOI.
DOI is maybe the most important single measurement in the oral cavity.
I would agree. It's measured by the pathologist from the basement membrane of the adjacent normal-looking mucosa down to the deepest point of invasion of the tumor cells.
And this is crucial. We're not measuring the overall tumor thickness, which might include, a part that's growing outward.
Right, not the exophytic part. We are measuring how deep the tumor is drilling into the subepithelial tissue. And that deep invasion correlates directly with the risk of occult cervical metastasis. That's the defining prognostic factor for these early lesions.
So we need to internalize the DOI thresholds. What's our rule of thumb?
If the DOI is 5 millimeters or less, you're generally in a T1 bucket. If it's greater than 5 millimeters up to 10 millimeters, you're usually looking at T2 status.
But the big one.
The big one is if DOI is greater than 10 millimeters. That single measurement is so powerful that it can push a tiny-looking tumor-like patient B's 2-centimeter surface lesion into T3 status, regardless of its surface dimension.
You called it a cliff edge for oral cavity risk.
It really is a cliff edge. The clinical and management implications are huge. A DOI greater than 10 millimeters means this patient has to be managed extremely aggressively.
Almost always a surgery-first pathway with a formal neck dissection.
Absolutely, because the risk of occult nodal disease climbs above 30%. That means you have to do an elective neck dissection, usually at the same time as the primary resection.
So if we had missed that DOI and just treated a 2-centimeter lesion with definitive radiation,
you'd be ignoring a very high probability of metastasis, which would lead to a high-risk failure pattern. Staging by DOI fundamentally dictates your initial management strategy from the get-go.
Okay, finally, we arrive at System 3, nasopharynx.
Yeah.
Or as you call it, the skull-based geography system.
That's right. Here, the entire framework is divorced from size in centimeters. Staging is defined purely by anatomical neighborhoods and the structures the tumor invades. It's a geography exam.
So let's run through the T category landmarks for nasopharynx. T1.
T1 is confined to the nasopharynx itself. Maybe some mild mucosal extension into the oropharynx or nasal cavity, but critically, no deep space involvement.
T2 is the classic upgrade point.
It is. T2 is defined by parapharyngeal space extension. This space is a deep, fatty region, and it's a pathway for the tumor to spread down and out, accessing critical structures. If you see tumor getting into that deep fat space, you're likely T2, even if the primary lesion looks tiny.
Okay, and T3.
T3 represents invasion of the bony structures of the skull base, the floor of the middle cranial fossa, the pterygoid plates, the sphenoid sinus and/or invasion of the paranasal sinuses.
And that's a fundamental landmark because it dictates your IMRT planning.
Absolutely. You have to include the entirety of those involved skull-based structures to get adequate coverage.
And T4 is the really devastating disease.
It is. T4 is extensive, locally devastating disease. We're talking intracranial extension, the presence of cranial nerve involvement. That's a clear T4 marker, or invasion of major distant structures like the orbit, the hyperpharynx, or the parotid gland.
Now for the N category in NPC, there are a couple of high-yield pearls we need to know.
Two specific ones. First, you must remember that retropharyngeal nodes count in the NPC system, even if they're small. In fact, N1 includes unilateral or bilateral retropharyngeal nodes and or unilateral level 2 nodes, as long as they meet the size and inferior extent criteria.
And the second pearl is the major anatomical upstage point for the N category.
Right. Nodal disease that extends below the caudal border of the cricoid cartilage. That pushes the N category into a higher, more aggressive designation. The cricoid is basically the lower boundary of the standard head and neck nodal basin, and breaching that border suggests more aggressive spread that needs more extensive field coverage.
Okay, let's take a breath and synthesize this. This is a complex matrix. The only way to manage it safely is to internalize this logic tree.
I call it the staging logic tree mnemonic. Every case starts by declaring the primary location in the biology, and that tells you which of the 4 paths to take.
Okay, lay them out for us. Path 1.
Path 1. If it's P16 positive OPC, your end stage is simplified. You're focused on laterality and the 6-centimeter cutoff. And remember, ENE does not alter the clinical end status. Your focus is on dose and volume selection based on protocol.
Path 2.
If it is P16 negative, or any non-OPC mucosal site like the larynx or hypopharynx, ENE is your staging and management escalator. Clinically, it upstages the N category. Pathologically, it is the single most important chemo trigger post-op.
Path 3.
If the site is the oral cavity, you must find and check the depth of invasion, DOI. DOI greater than 10 millimeters defines T3-like behavior. It means upfront surgery and likely comprehensive adjuvant therapy.
And path 4.
If the site is NPC, forget size. You are looking at geography, parapharyngeal space for T2, skull base for T3, cranial nerves for T4.
That structured framework makes all the difference. So let's apply it. Let's go back to our initial 2 patients and run through a couple more high-risk scenarios, translating the stage directly into the plan.
Let's do it.
Scenario 1, patient A solution. 50-year-old, P16, positive OPCT, T1, N1. That's a clinical stage 1. So what does that tell you?
It tells you the prognosis is excellent. The probability of distant failure is relatively low compared to, say, a system 2 disease.
But the plan impact,
Yeah.
you have to be cautious.
Very cautious. Definitive radiation to 66 or 70 gray is still the standard of care for definitive treatment. True de-escalation of dose or volume, or skipping chemo. That depends entirely on the total nodal burden and has to be done within a specific protocol like NRG or DEA, SCA-LATE.
So you treat the biological risk profile, which is low, but you still have to treat the physical disease burden.
You got it.
Scenario 2, patient B solution. The 60-year-old smoker with the oral tongue mass. If imaging or biopsy shows DOI greater than 10 millimeters, this patient is fundamentally different.
Completely different. What this tells you is that this small surface lesion is biologically a high-stage T3 tumor.
And the plan impact is immediate.
Immediate. It mandates a surgery-first pathway. That almost certainly means a comprehensive neck dissection on that side, even if the clinical exam was initially N0.
And after surgery.
After surgery, you're strongly considering adjuvant radiation based on margins, number of nodes, or the presence of PNI or LVI. If we had failed to get that DOI, we might have wrongly chosen definitive radiation, and that would likely lead to a recurrence in the neck. A much tougher salvage situation.
Okay, scenario 3, adjuvant trigger. Let's say we have any P16 negative tumor, maybe laryngeal primary. They go to surgery, and the path report comes back with confirmed pathologic ENE.
This tells you that this tumor has a high inherent risk for local regional recurrence that radiation alone just can't adequately cover.
So the plan impact, based on those big trials, is non-negotiable.
It's non-negotiable. Postoperative radiation, 60 to 66 gray, must be delivered with concurrent cisplatin. Standard dose, 100 milligrams per meter squared every 3 minutes, unless there's a major contraindication. Pathologic ENE elevates treatment to the chemoradiation standard.
And finally, scenario 4, NPC coverage. A patient with NPC, and they have documented invasion into the skull base, but no intracranial involvement.
That puts them in the T3 category. And what that tells you is the tumor has breached that protective bony boundary. That requires specific attention to your target volume geometry.
So the plan impact is clear.
Very clear. Definitive IMRT to about 70 gray. The T3 status specifically mandates targeting of the skull base, often the cavernous sinus and the retropharyngeal nodes to the high-dose level, and of course systemic therapy induction, concurrent or both is required, based on the total stage and your institutional protocols.
Let's discuss a crucial connection here that goes beyond just memorization. Toxicity management, things like long-term dysphagia or mandibular necrosis. They're often the result of failing to use the staging system correctly to define the risk and the volume.
This is our staging-linked toxicity anchor. And the classic mistakes we see are almost always driven by confusing prognosis with intensity or by missing those key high-risk features. The first mistake is often over-treating by misinterpreting favorable prognosis.
Right, a common error. A resident sees stage 1 on a P16 positive chart and just reflexively shrinks the standard radiation planning target volumes or tries to lower the dose outside of a formal de-escalation protocol.
They're treating the stage number, not the required anatomy.
And the consequence is simple. You risk a marginal miss and a local regional salvage failure. You could trade a curable cancer for a very challenging salvage problem that requires larger fields, higher doses to critical structures.
And thus, far worse long-term function and a much higher risk of severe dysphagia.
And the opposite mistake is just as dangerous. Undertreating by missing high-risk features.
This happens all the time when you fail to recognize those high-risk switches in the P16 negative setting, like a high DOI in the oral cavity or a convincing case of clinical ENE. If you treat a T3 oral tongue tumor, defined by its 12 millimeter DOI as if it's a simple T1, you are virtually guaranteeing a recurrence.
And when that recurrence happens, the patient has fibrosis, distortion. It forces you to use highly conformal IMRT, which can actually deliver a worse cumulative mandibular dose.
Or dramatically increase the dysphagia risk because you need much larger, often bilateral field expansions. A staging error on the front end leads directly to a significantly worse toxicity profile on the back end.
So your board-level stance on this has to be crystal clear.
It has to be. Stage informs prognosis, high-risk features inform intensity. Never confuse the overall biological outlook with the immediate demands of treating the disease safely.
Okay, let's move into our board review section. This is designed to identify the specific traps that examiners love to deploy to test if you're using the right staging book and, the right vocabulary.
All right. Trap 1. Using the wrong end vocabulary in P16 positive disease. If you are discussing a P16 positive oropharynx case and you use the term N2C to describe bilateral nodes, you've signaled that you're using the old system or the P16 negative rules.
Right. N2C, N2A, N2B, they simply do not exist in the HPV positive framework.
Doesn't exist. It's N2 for any bilateral or contralateral nodes under 6 centimeters.
Trap 2.
Upstaging P16 positive clinical N based on ENE. This is one of the most common mistakes in oral board scenarios. If a patient with P16 positive T2 disease has obvious radiographic ENE and you immediately call it N3B or even N3, you are incorrectly applying the P16 negative rule set.
Clinically, ENE does not change the N category of the HPV positive system. It's prognostic, sure, but it's not management escalating outside of a specific trial.
Exactly. And trap 3, missing the paramount importance of depth of invasion in oral tongue staging. If you stage an oral tongue primary just by its surface dimensions, say a T1 based on size, you will fundamentally misstage that patient if the DOI is high.
And you'll fail to account for the single most important high-risk variable driving the need for a neck dissection.
Always ask for the DOI if the primary is oral cavity. Always.
Okay, let's run a quick rapid recall drill to cement these key pivot points.
Let's do it.
2 centimeters tonsil tumor, P16 positive, T1 or T2.
T1 if it's exactly 2 centimeters. If it was 2.1 centimeters, it immediately moves to T2.
In P16 positive OPC, bilateral nodes under 6 centimeters, N2 or N3.
N2. Laterality defines the split, not the specific number of nodes below that 6 centimeter threshold.
In P16 negative disease, what pathologic feature is the major trigger to add concurrent cisplatin post-op?
Extranodal extension, or ENE, based on the RTOG and EORTC data.
In oral cavity, what DOI threshold is the cliff edge that can push a small lesion into T3 behavior.
Greater than 10 millimeters. That DOI forces an aggressive, typically surgical pathway.
Last one. In NTC, skull base invasion without intracranial extension, T3 or T4.
T3. Skull base invasion is the definitional feature of T3 in that system, reflecting invasion of the bone.
Excellent. Let's conclude the board review with our Board Blitz 4 typical multiple-choice questions designed to test your ability to apply these concepts across the 3 different staging systems.
All right.
Question 1. A patient has a P16 positive tonsil squamous cell carcinoma with a 2.5 centimeter primary and a single 4 centimeter ipsilateral lymph node. Imaging suggests extramodal extension. What is the AJCC Eighth Edition clinical stage group most consistent with this presentation? A, stage 1, B, stage 2, C, stage 3, or D, stage 4?
The best answer is A, stage 1. We use path 1 logic here. P16 positive oropharynx. The 2.5 centimeter tumor is a T2. A single ipsilateral node under 6 centimeters is N1. And critically, ENE does not change the clinical N status here. T2N1 is grouped as an early favorable stage.
Question 2. A patient undergoes resection for oral tongue squamous cell carcinoma. Pathology shows a 1.8 centimeter tumor with 6 millimeter depth of invasion. One ipsilateral level 2 lymph node is positive at 1.5 centimeters with confirmed pathologic extranodal extension. Which nodal risk implication is most important for adjuvant planning? A, observation is appropriate because the node is small. B, adjuvant radiation alone is sufficient. C, pathologic ENE strongly supports adding concurrent cisplatin to postoperative radiation. Or D, this should be treated like P16 positive oropharynx.
The correct choice is C. We're using path 2 logic. P16 negative oral cavity disease. Pathologic ENE is the definitive indication for combined modality therapy. It's even more important than the positive margin status or the number of nodes. The DOI of 6 millimeters is important, but it's overshadowed by the ENE in dictating the use of systemic therapy.
Question 3. In nasopharyngeal carcinoma, which finding most directly upgrades the primary tumor from T2 to T3? A. Extension of the posterior oropharyngeal wall. B. Invasion of the pterygoid plates or sphenoid sinus. C. Involvement of the skin of the face. Or D. A 2-centimeter primary tumor size.
The answer is B, invasion of the pterygoid plates or sphenoid sinus. As we established, NPCT categories are purely defined by deep spaces and bony structures. Invasion of the bony skull base, which includes the sphenoid or pterygoids, is the primary T3 landmark.
And question 4. A patient has a P16 negative T2 tonsil tumor. Pathology reveals a single 3-centimeter lymph node with confirmed pathologic ENE, which best describes the AJCC staging impact of the ENE and the resulting management. A. It upstages the N category to N3B. It upstages the overall stage group and strongly drives the decision for chemoradiation C. It changes the N category to N1D. It does not change the N category.
This one requires combining staging and management. While ENE does change the pathological N category in the P16 negative system, the most impactful and critical distinction for the boards is the management escalation that results. So the best answer is B. Pathologic ENE upstages the overall stage group, usually to a stage 3 or 4, and most importantly, it mandates adding concurrent systemic therapy to the postoperative radiation plan. It reflects that high-risk nature.
To summarize this entire complex discussion, let's distill these facts into 5 quick clinical pearls that you can use immediately in the clinic to avoid those dangerous pitfalls.
Okay. Pearl 1. Always declare the staging system out loud when discussing a case. Whether you're in chart rounds or in the oral board, say, this is P16 positive oropharynx staging, or this is NPC staging. This simple act forces you to commit to the correct logic tree and avoid mixing the rules.
Pearl 2.
P16 positive stage 1 is a massive favorable bucket of patients. It tells you prognosis is good, but you have to remember that it does not tell you the disease is trivial. And it does not mandate reflex de-escalation of dose or volume outside of a formal, peer-reviewed trial protocol. Treat the anatomy, trust the prognosis.
Pearl 3.
ENE is the P16 negative management escalator. Remember this for Path 2. Especially pathologic ENE, which is the primary feature that drives the discussion directly toward adjuvant chemoradiation post-surgery. That's based on decades of foundational Phase 3 data. If you see pathologic ENE in a P16 negative case, think cisplatin. Depth of invasion defines oral cavity risk. Greater than 10 millimeters is the cliff edge. It's the single most important metric that tells you a small surface tumor behaves like an advanced T3 disease, and it dictates a surgery-first approach and a high probability of adjuvant therapy.
And Pearl 5.
NPC is purely a geography exam. Forget the calipers and the T1-2 centimeter cutoffs. Focus on the spatial landmarks, parapharyngeal space, skull base, and cranial nerves. Mastering the T staging for NPC is mastering the local anatomy.
So what does this entire review tell us?
I think the central conclusion we have to reiterate is that safe and effective management of head and neck cancer requires recognizing that there isn't one staging system.
Not at all. There are 3 distinct systems, each with unique biological drivers and resulting rules.
Absolutely. The P16 positive staging uses laterality and a single 6-centimeter cutoff to reflect improved biology, leading to those favorable stage groups.
Right. And the P16 negative staging is where ENE and DOI act as these high-risk switches that change everything about your intensity. And NPC staging relies purely on identifying skull-based geography.
Stage informs prognosis. High-risk features drive intensity. If you use this precise framework, you will safely and confidently navigate the complexity of managing patients who may look similar anatomically, like our initial patient A and patient B, but who are entirely different biologically and require vastly different treatment algorithms.
Now that we've successfully reviewed the intricacies of diagnosis, localization, and staging these diseases, our next session is going to look toward treatment principles that the boards love to use to test your clinical judgment, fractionation, and time.
Specifically, we will dive into the radiobiology of accelerated treatment, why missed days matter so crucially in head and neck cancer, and how we can safely compensate for gaps in treatment without compromising tumor control probability.
It's an essential clinical topic, and it builds directly on the necessity of high-intensity treatment that we talked about today.
Looking forward to it.
Complete practice oral boards at radonsmartlearn.com. and subscribe to Radon Smart Review for our next high-yield tutoring session. Thanks for tuning in.